Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Madrigal Pharmaceuticals.
GI clinics across the U.S. are seeing more and more patients whose liver disease is driven by obesity, type 2 diabetes, and other cardiometabolic risk factors. Metabolic dysfunction-associated steatohepatitis, or MASH, is the tipping point where steatosis turns into active inflammation, hepatocellular injury, and fibrosis. And that shift puts patients on a dangerous path towards cirrhosis, liver cancer, and even the need for liver transplantation. But with non-invasive testing and emerging therapies that can change the course of MASH, we can offer patients a very different path, one that focuses on detecting fibrosis in earlier stages, improving steatohepatitis, and in some cases, even reversing cirrhosis. Welcome to the first episode of Medscape's in-depth CME TV docuseries, Managing MASH in the Modern Era. I'm your host, Taryn Winterbrill. Today, we're in Cleveland, Ohio, home of the Rock and Roll Hall of Fame and the acclaimed hepatologist Dr. Naim Alkhouri. A rock star in his own right, Dr. Alkhouri is a renowned international MASH expert and currently leads one of the busiest liver clinics and clinical research programs in the U.S. In this episode, he'll guide us through the practical steps of screening and interpreting non-invasive test results to identify those at risk for MASH progression. Dr. Alkhouri, we are thrilled to have your participation in this series.
It's my pleasure.
So today we're focusing on how to identify MASH for GI specialists. But before we dive in, can you briefly explain the difference between MASH and its broader umbrella term, MASLD?
Yes, so MASH and MASLD are closely related, but they're not the same thing. MASLD refer to steatotic liver disease in the setting of metabolic risk factors such as diabetes and obesity, whereas MASH is the inflammatory and often fibrogenic subset of MASLD. MASH is steatohepatitis with hepatocellular injury, inflammation, and typically some degree of fibrosis.
That's very helpful. Thank you. Okay, now, can you imagine a patient at risk for MASH who you might see in the clinic and then describe that patient for us?
Okay. She's a 59-year-old Hispanic woman, quick-witted and social. She has type 2 diabetes, dyslipidemia, and a BMI of 31.1, consistent with obesity. Her hemoglobin A1C is at 6.5%. She is on metformin extended release, 1,000 milligrams daily, and atorvastatin, 80 milligrams daily. Her primary care physician noticed mild but persistent elevation of her liver enzymes, and steatosis was found on a subsequent ultrasound. She was referred to the clinic to sort out the cause and severity of what they found.
And what specifically makes this patient at higher risk for MASH?
Well, she has several converging risk factors. Number one, her metabolic burden. She has obesity, type 2 diabetes, and dyslipidemia. All increase the risk of steatohepatitis and fibrosis progression. And diabetes is probably the strongest single risk factor among these. Number two, persistent liver enzyme elevation. Even mild chronic ALT and AST elevation in this context should raise suspicion. Number three is her age. Being above 50 is associated with higher likelihood of advanced fibrosis. And the list goes on. Number four, her ethnicity. Progressive MASH is more prevalent, and advanced fibrosis and liver-related complications are more common in Hispanic and Latino populations. So when these factors converge, the pretest probability of liver fibrosis is really high.
I imagine many people are watching and are thinking, I see patients like this in my practice all the time.
Most likely they are. This is a very common profile. Patients with metabolic syndrome, mild elevation in liver enzymes, and no obvious symptoms. The key is to notice those sometimes subtle clues.
But why not just employ a watchful waiting strategy for this patient?
Because watchful waiting essentially allows silent progression. Fibrosis stage is the main predictor of liver related outcomes and overall mortality. And clinically significant risk begins at stage 2 fibrosis. If we identify stage 2 and 3 fibrosis, we can intensify lifestyle and metabolic interventions and start treatment with an FDA approved MASH therapy, such as resmetirom or semaglutide. But if we wait until she has cirrhosis, her options become limited and often focus on managing complications rather than reversing fibrosis.
So the goal is to intervene before they cross that threshold into irreversible damage.
Exactly.
This case illustrates key early red flags: type 2 diabetes, obesity with at least one additional cardiometabolic risk factor, and persistent ALT AST elevation. Now, current guidelines stress that any patient with these features should be evaluated for MASLD and assessed for advanced fibrosis and high risk MASH. Now, like hypertension or high cholesterol, MASH is usually asymptomatic until complications appear. We don't wait for a stroke to treat blood pressure, and we shouldn't wait for decompensated cirrhosis to look for fibrosis. Okay, so let's turn now toward evaluation. What do the guidelines recommend for risk stratification?
Most now recommend a two-step non-invasive pathway. So step one is to calculate the FIB4 index using age, AST, ALT, the liver enzymes, and platelet count. Patients in the lower risk range below 1.3 in adults under 65 years of age and below 2.0 in those 65 and older can usually be managed and monitored in primary care with FIB4 repeated every couple of years depending on risk factors such as type 2 diabetes. For patients with high risk, step 2 is to measure liver stiffness, typically with vibration controlled transient elastography or VCTE. And this helps to either rule in or rule out significant fibrosis. These tests complement each other. FIB4 is free, widely available, and effective for ruling out advanced fibrosis at lower cutoffs, while VCTE adds specificity for significant fibrosis or cirrhosis.
Could you kindly describe a scenario where our patient comes back with a FIB4 score that suggests further evaluation?
Think so. Let's see. On labs, the AST for our patient is at 55 units per liter, ALT is at 44, with a platelet count of 182,000. Using these values, we can calculate her FIB4 and it's at 2.7. That means she's no longer falls into the reassuring lower risk category of less than 1.3. This signals to us that she may have significant fibrosis and needs a more detailed assessment. And since our patient's FIB4 is above the low risk threshold, our next step is to measure her liver stiffness with VCTE.
Okay, so let's say then you perform VCTE and it's 12.5 kPa with a cap of 340. What would this suggest?
A liver stiffness measurement or LSM at or above 8 kilopascals suggests significant fibrosis, so stage 2 or higher. At around 12.5 kilopascal, we are in the F2, F3 range with the high risk of progression. This is more like an F3 patient. A CAP score of 340 falls in the severe steatosis range, meaning there's fat in more than two-thirds of the hepatocytes. So when you put that together with the FIB4 of 2.7 and her other comorbidities, my clinical diagnosis would be probable MASH with F2, F3 fibrosis, and I'd manage her as high-risk patient with closer follow-up and, more importantly, MASH-directed therapy.
And where does ultrasound fit into risk stratification?
So ultrasound can detect steatosis, but more recent guidelines do not require ultrasound to confirm steatosis before you start risk stratification, and ultrasound is not reliable for staging fibrosis. If a patient already has steatosis documented by any modality such as CT scan or MRI and meets metabolic criteria, I do not delay VCTE while waiting for another ultrasound.
By following a two-step non-invasive pathway, Dr. Alkhouri used FIB4 and VCTE to refine this patient's risk stratification, from steatosis with abnormal labs to MASH with significant F2, F3 fibrosis, which triggers a very different treatment plan, one that might halt and possibly reverse fibrotic progression and lower her risk for cirrhosis, liver cancer, and possible transplant. Now, as we continue, think about a patient in your practice who fits this profile and how you might apply this two-step algorithm. Okay, so we've now seen you move stepwise from FIB4 to VCTE. Beyond that core sequence, are there other non-invasive tests that you find useful?
Yes, I haven't mentioned the enhanced liver fibrosis or ELF test yet, but it's a serum fibrosis panel that measures three proteins involved in scar formation and turnover. It's helpful when VCT is not available or when results are discordant with the clinical picture.
And can you give us an example of how you would use ELF to clarify discordant results?
Yes, I tend to use ELF as a tiebreaker, as a way to either confirm or disprove my initial suspicion. So let's say the patient has high liver stiffness on VCTE, but a clinical profile that doesn't quite fit. Maybe no diabetes, just modest obesity, normal platelet count. If this patient's ELF score was low, it would make me question the VCTE results and repeat it or consider a liver biopsy or another non invasive test. If the patient's ELF score was between 9.8 and 11.2, that would confirm that this patient has F2, F3 fibrosis.
And what are some factors that can influence the results of these non-invasive tests?
Great question. Each test has its own limitations. FIB4 cutoffs are higher for older patients, as we mentioned earlier, and any non hepatic cause of thrombocytopenia can drive up the score and overestimate fibrosis risk. For VCTE, obesity and a high BMI over 40 can affect its reliability even when we use the XL probe. Significant inflammation with ALT levels above 200 units per liter can also transiently increase liver enzymes and stiffness, making fibrosis appear worse than it is. We also avoid doing VCTE in patients with ascites because the fluid interferes with wave propagation, and in reality, these patients already have decompensated disease.
And the ELF test?
For ELF, the score can be influenced by other fibrotic conditions, such as rheumatoid arthritis or pulmonary fibrosis, and it tends to increase with age. So, in an older patient with multiple fibrosing comorbidities, a modestly elevated ELF may not be specific to the liver.
And do you adjust your approach based on these limitations?
Yes, in severe obesity, I anticipate limitations with VCTE, so I rely more on blood-based tests like ELF. In older adults, I apply the higher FIB4 cutoff and interpret modest stiffness elevation in the context of comorbidities, frailty, and also competing risks.
And is there still a role for liver biopsy? And if so, in what situations?
There's still a role, but it's less indicated these days. I consider biopsy when non invasive tests are discordant and the result will change management for clinical trials where histologic endpoints are required, and then for atypical cases.
So, what's an example of an atypical case?
Let's see. A good example is when there is concern about overlapping autoimmune hepatitis or cholestatic liver disease, where histology will actually guide the diagnosis and also the treatment.
All right, so let's pause and organize what we've just heard into a simple mental model. Think of non invasive fibrosis assessment as three layers. First, FIB4 helps you decide who is low risk and who needs additional testing. Second, VCTE adds a liver stiffness signal to help rule in or rule out significant fibrosis. Third, ELF can act as a tiebreaker when those first two tests don't agree or when VCTE isn't available. But no single number should drive management in isolation. always ask, does this result make sense for this patient? If it doesn't, that's your cue to repeat the test, combine tools, or, in selected cases, consider biopsy. Okay, so let's close the loop on our patient. She has a clinical diagnosis of probable MASH with F2, F3 fibrosis. How do you explain these findings to the patient?
I'd sit with the patient and explain that she has inflammation and scarring in her liver related to her metabolic conditions, and that the scarring is at a stage where we still have a good opportunity to slow or even reverse some of the damage. But if we do nothing, it could progress to cirrhosis and its complications. From there, we'd map out a plan. What dietary changes would be realistic for her, how much weight loss we should aim for, and simple ways to add more movement into her day. We'll also go through their diabetes and cholesterol medications to be sure we're optimizing cardiometabolic risk. If she meets treatment criteria, I would introduce the option of MASH targeted therapies and explain how they fit into the overall plan. But I think you're saving that discussion for the next episode.
You got me. So, as we wrap up this episode, are there any key takeaways you'd like to share with our audience?
Yes, it's important to recognize that the patients we're talking about are already in your waiting room. MASH is usually silent until it's late, but the tools to find fibrosis earlier are in your hands today. If you consistently apply a simple, non invasive pathway and act when risk is high, you can change the natural history of this disease for your patients. The opportunity for gastros right now is really enormous, and so might be the burden of this disease. But we can move from reacting to cirrhosis to preventing it, and that shift starts with how we choose to evaluate the next at risk patient who walks into your clinic.
Dr. Alkhouri, that is powerful advice. Thank you so much for speaking with us and for sharing such a clear roadmap for identifying MASH in everyday practice.
My pleasure. I've enjoyed it.
To recap, a simple, non-invasive pathway can be the difference between catching fibrosis early and meeting it for the first time as cirrhosis. In our next episode, we'll focus on what comes next, how to manage MASH once you've identified patients at risk for progression. Between now and then, I encourage you to talk with your team about how non-invasive testing fits into your clinic's broader approach to liver disease, so everyone shares the same language and goals around risk stratification. On behalf of Medscape, I'm Taryn Winterbrill. Thank you so much for joining us for this first episode of Managing MASH in the Modern Era. Be sure to complete the post-activity quiz and evaluation to receive credit. And we look forward to seeing you next time as we continue to explore how GI specialists can lead the way in improving outcomes for patients living with MASH.